everybody. I would like to thank everyone for taking time out of their day to come today. See a lot of familiar faces out in the audience. I think it's great that we're able to do this every year, and I'm very excited that we've had such support. And of course, thanks Francis and Rosalind for all your help. I am from Brooklyn, so if I talk real fast, just raise your hand and slow me down. So I'm going to talk about a really exciting topic that has really hit mainstream and is so important. It's the role of screening for lung cancer. Obviously, this is just a cartoon of what a lung cancer looks like inside of our lungs. So the statistics for lung cancer, and some other people may be covering these, but they're pretty. Lung cancer is the most prevalent cancer in America and actually worldwide. It's more common, and there's more deaths associated with lung cancer than the next four cancers, which includes colon, breast, pancreas, and the prostate. And as you can see, the numbers even historically are in the 100,000s. And the problem is that a lot of patients not only are diagnosed with it, but oftentimes die very quickly. Worldwide, it's obviously a devastating process. 1.8 million people plus died just in 2002. These are obviously historic numbers. And those numbers aren't getting any better, unfortunately. The biggest reason is because early stages are elusive, and which means that it's hard to find this cancer when it's early on. And overall, if we find it in the late stages, the prognosis deteriorates as we get into the later stages, such that historically and unfortunately still for the most part, the 5-year survival of all comers, which again predominantly includes late stage patients, is approximately 5%. And the reason is because by the time someone presents with a symptom to their doctor's office, any symptom associated with lung cancer, the chances that they're about a 75% chance that their cancer is already advanced. What are some of the symptoms of lung cancer? Now, obviously some of these are more vague than others. Systemic effects are things like weight loss, paraneoplastic syndromes, which are clumping of the feet, changes in blood cells. Metastatic disease could include things like seizures, if there's brain metastases, enlarged lymph nodes, if there's lymph node metastases, pain in the bones, if there's extension into the bones. But some of the kind of more benign symptoms include something like a cough, especially a cough that doesn't go away, fevers, shortness of breath. A really big one is coughing up blood, called hemoptysis. That's obviously a big trigger of something bad going on. And then things like rib pain, chest pain, fatigue. So as you can see, sometimes the symptoms are almost impossible to say, well, if everyone that coughed in the world had lung cancer, we'd really be in trouble. And so you can see that sometimes the symptoms, even when patients present with them, are not necessarily diagnostic of one disease process, but we should be thinking about that when these symptoms occur. Again, when we think about the 5-year survival, it was considered a cure. Is considered that 5 years after the time of diagnosis, there's no evidence of cancer within a patient's body. So the cures are the stage 1s usually. Those are ones that up to 94% can have cure with surgical treatment. And we'll go over some of those results a little bit later on. But you can see as we go higher in stage, and that higher in stage means that the tumor is either more advanced in the part of the lung. It can include advancement into the lymph nodes. And stage 4 includes advancement into other organ systems like the liver, the brain, the bone. But the key is if we can find patients in the early stage, and especially if we can treat them with surgery, which is considered the mainstay of treatment at this time for a cure, we can actually have survival rates that are 70, 80, even 90%. And obviously, in addition to just finding it, offering appropriate treatment. So making sure we get the diagnosis correct, aggressively looking for lymph nodes, looking for metastases, doing all our scans, and then obviously, a lot of our patients are elderly. They may have comorbidities like heart disease or lung disease. So we want to make sure that whatever treatment we have, we optimize those comorbidities. And of course, that the surgery goes without a hitch and patients do well from surgery. So again, when we talk about early detection, the reason that we find early detection is for screening. Now currently, almost as of today, the screening has not been traditionally covered by insurance. There's a couple of studies I'm going to talk about, the NCI trial and the ILCAP and the family trials. We go over those in just a minute. Those are research studies, which means patients get enrolled, they volunteer to participate in these trials, and both of those were looking at the role of low-dose, non-contrast CAT scans looking for early-stage lung cancer. The NCI trial is actually a pivotal trial that I'm going to tell you a little bit more about some of what's happening now. But the ILCAP and the family has been open since 1993, have over 50,000 patients. And those are still enrolling, still accruing, and very powerful studies. Again, we have to do, in order to, if we find a nodule or something on a scan or an x-ray, we want to be able to accurately and safely diagnose that patient. We have all kinds of new tools and technologies that allow us to do that in a minimally invasive outpatient procedure. Of course, we talk about making sure that we find any advancement of the tumor, specifically into the lymph nodes, and then, of course, doing the surgery. And one of the things that we're very proud to offer here is almost 90% plus patients are able to be treated with what's called minimally invasive or thoracoscopic surgery, where we don't have to cut the ribs, we don't have to cut the muscles. Patients can have a significantly lower postoperative pain, significantly easier recovery, back to normal functions. And of course, in those patients who, let's say, we do think we hope to find early stage cancer, but we find something more advanced, we have to be able to offer them additional treatments like chemotherapy and radiation. So we kind of have to work as a team. And again, if you look again at this graphic of what early stage does for us, these are 10-year survivals. Some of these this is from the ILCAP study, which was really aggressive and really going after even the tiniest of nodules. You see that highest line up there are stage 1 cancers that are less than a centimeter in size. You will never see something that's less than a centimeter in size on a chest x-ray. These are all found on CAT scans. But you can see we're at 94% at 10-year survival. That's phenomenal. Those are amazing results. But as the lesions get larger, and of course as we find more metastases, the results become less impressive. So the word screening means that we're going to look for a disease process that has no symptoms at the time that we're looking for it, and we're going to look for it. And the purpose is that we're going to find it so early that if we intervene at an early time, before symptoms, before metastases, we're going to have the ability to affect the patient's survival. If you look at the little graph on the right-hand side, the cure rate for lung cancer, again, that 5-year disease-free of all comers is less than 10%. It's about 7%. And that's the only one of those cancers that are listed up there that don't have a screening test. Colon cancer, we have a screening test. We used to have anything from digital rectal exams to screening of stool for blood, and now, of course, colonoscopies. You can see that's the one that's not as favorably, not too many people are excited about their colonoscopies. But still, those are patients we're finding earlier. We have a 50% cure rate. Breast cancer with mammography and now MRIs, 80% cure rate. Prostate cancer, there's a blood test. With the blood test, we can identify prostate cancer. So look at the 5-year cure rates of those cancers because we're catching them early. So what are the tests that we can use? Unfortunately, the lungs are hidden inside of our chest cavity. There's not a lot of easy ways to find them. You can't feel for them, and not like a self-breast exam in women where you can look for lumps. We really have to rely on x-ray tests. And the types of x-ray tests that patients can get offered include anything from a chest x-ray, which includes 1 view, 2 views, sideways views, CAT scans that can include IV contrast or be without IV contrast, and then more sophisticated tests like PET scans, MRIs, and bone scans. And I don't have enough time to go over each of these in detail, but each of these tests has its own limitations, benefits, risks. And currently, the one that has the most potential with the lowest risk factor is a low-dose, non-contrast CT scan. Again, so screening is subjecting asymptomatic patients. You're going to say, hey, I think this population of patients are at risk of having this disease process. Obviously, things like breast cancer, you say women, they have breasts, they're higher risk of breast cancer than men are. Are you going to catch every single breast cancer? There are men that have breast cancer, but you're not going to screen all men because the risk is much lower. So you want to identify risk factors. We know that in lung cancer, that smoking is directly related to the risk of developing lung cancer. There's plenty of non-smokers, unfortunately, that develop lung cancer, but the risk profile that goes along with high risk is a smoking history. The higher the risk factors that you pick, the more likely you're going to find the disease process. Of course, the key here is that the treatment will change if you find it early. Again, we'll talk about surgery. And if you're looking at too tight a risk factor, if you're saying only people that smoke more than 4 packs a day, that are between the ages of 55 and 75, and that worked with asbestos, well, probably all those patients are going to have lung cancer, but you're going to lose all the other people on the side. So you really have to identify the population that makes sense to look for it. Again, is screening worth it? When we look at with the ILCAP study, which is the biggest trial, the risk of finding a lung cancer in high-risk patients was 1.3% on the first scan and 0.3% with the annual follow-up scans done every year. If you change some of that, let's say, well, let's look for, and the ILCAP usually started with patients between 45 and 50. If you say, well, let's look for older patients, because the older they are, the more likely they are to develop lung cancer, you can see that the baseline detection increases and the chance of finding it increases. But if you still compare that to mammography, we're actually right at baseline. We actually do better than we do with mammography. The cost of a CAT scan is, unfortunately, is about 375 degrees, but the overall savings are such that you will save money in the long run if you find these patients early, treat them now, prevent their cancer from getting bigger, because it will. If you wait, it's going to grow, and then have to treat with them with chemotherapy, radiation, and of course, obviously, loss of income, loss of lives. So if you calculate the analysis, we're presuming that all the patients that we're going to screen are healthy enough to undergo the treatment that's going to be proposed. So again, you have to make sure that you're not picking patients that are nursing home patients on a ventilator, or someone whose heart is really sick and can't undergo surgery. There are some limitations to the screening, but if you're going to pick patients who are going to be alive 5 years from now, you want to cast a tumor right now before it's causing symptoms and before it gets big enough to be metastatic. Again, if you don't catch these patients early, we talk about that mortality, the 5-year mortality, 85% of these patients will die of their disease if it's not caught early. The downside of every test is that there's some false positives. So there's going to be patients who have lesions on their lungs or nodules that we're going to see on the CAT scans that are not cancer. And the key here is of course, to weed those out. We don't biopsy every single nodule and resect every single lung that's got a ditzel on it. We'll talk about a little bit about some of what we do as surveillance. So we'll do a baseline scan and then we'll follow it. And if there are any nodules that are small or not worrisome looking, we can watch them and see how their behavior is over short periods of time. And again, what are the risks of a CT scan? Well, the biggest risk is what's the cumulative dose of radiation. Our body adds up radiation every day. It's like putting money in the bank and never taking it out. There's theoretically only so much our body can take. The theory is that if you do have a high dose of radiation exposure, that 30 years from now you can have a significant negative effect. Things like breast cancers, thyroid lesions, leukemias can be associated with high doses of radiation. And that's the reason that the CAT scans we're trying to propose doing a minimal dose that would give us the pictures that we need. And again, if you're thinking about someone who's in their 60s and their 70s who are otherwise healthy, you say, well, is it worth it to have a little bit of radiation now and not worry what's going to happen when they're either 100 or 110? And the answer is it probably makes sense to do the scan now. The National Cancer Institute trial, which is the big trial that really catapulted screening into the limelight, just recently closed in 2010. This was a randomized trial. They had a very narrow profile. You can see 55 to 74. Extensive smokers, so these are 30-pack years or more, and they are including people that were currently smoking. And they would compare these patients to having x-rays once a year versus a low-dose CAT scan once a year. And they actually stopped halfway in the middle of the trial because they found that the people that were getting CAT scans had a significantly reduced mortality rate from their lung cancer than people that had x-rays, and it was unethical to continue the trial. Why would you subject more patients to a bad test? So they literally just stopped and said, you know what, this doesn't make any sense. CAT scans are clearly superior to chest x-rays. So when we talk about, what are these risk factors? So ILCAP, again, that's the ongoing trial that started in Cornell in 1993. Their guidelines are actually more generous. We're having age 40 to 85. The relatively lower pack year history of smoking, 10-pack years, which is a pack per day for 10 years, which is the same as 2 packs a day for 5 years or half a pack a day for 20 years. And asbestos exposure or radon gas exposure, a primary relative with lung cancer, that can include a brother, a sister, or parents. And again, patients who are healthy enough to undergo surgical resection, although the caveat is that we've actually enrolled patients who may benefit from alternative treatments, and we could talk about that in a minute as well. I'm going to ignore that last line for just a second. So the conclusion is that lung cancer is one of the deadliest cancers out there, and the reason is because early stages are hard to identify, but if we can catch them early, the surgical cure rates are actually very, very encouraging. Again, screening is going to be the way we're going to find patients early with a low-dose, non-contrast CT scan. The surgical treatment is currently the gold standard, but there are some newer radiation treatments which are actually very sophisticated and can be helpful in patients who can't undergo surgery, and those are showing some promise. And then the biggest concern that has historically been is, what about false positives? Everyone in this room probably has a nodule in their lung if we do a CAT scan on everyone in here. Everyone's got nodules. We live in America, there's pollution, there's dust in the air, so we're all going to have some nodule, but the question is, which of them are worrisome, which of them are not? How do we figure that out? And in many cases, it's tincture of time. We follow nodules with repeat CAT scans and see if they change, if they fall into the suspicious but not terribly worrisome category. The exciting news that I wanted to say is just a couple of days ago, Medicare or CMS has agreed, starting February of 2015, to start paying for annual CAT scans for their high-risk patients. These patients have to have a consultation with either a oncology professional or a surgeon to discuss what the risks, the pros and cons are of the risk of radiation, as well as the findings. Again, if everyone freaks out when they hear they've got a nodule in their lungs, again, we can't biopsy all those people, but there's a consultation portion included in it. They're including, again, a really pretty narrow range, 55 to 74. We have lots of 80-year-old patients, especially in this community, who are very healthy, who have a smoking history, who would actually be excellent candidates. So I think that there's still some leeway that we're working on, but this is the inclusion criteria they've agreed to. Again, no significant symptoms. That doesn't mean if someone coughs once a month that that's considered a symptom. We're talking about some of the other symptoms. They're asking for a 30-pack year history, and they must have quit smoking no more than 15 years ago. So if they smoked from the age of 20 to 50, but now they're 75, that doesn't count. So those are considered no longer high risk. They're predicting that if we can get all these patients to get their CAT scans, we'd probably reduce lung cancer deaths by 20,000 patients a year. There's approximately 5 billion patients with Medicare who would currently fit under this criteria. But the key is not only once Medicare covers it, all the private payers will as well. So the exciting news is usually once Medicare agrees to something, everyone's like, hey, that's not a bad idea. More to come on when this is actually going to go and how they are going to consider making separate facilities like screening centers. And so there are some criteria that are still coming down the pike. But the fact that this passed and that there's so much enthusiasm is great. So now's the time to see your doctor, ask if you're a candidate for screening, go over your risk profile, talk to your family and friends. If they are high-risk patients or have profiles that would fit for high risk, they should talk to their doctors. Obviously, smoking cessation is the key to any one of these processes, avoiding secondhand smoke when possible. Anyone that works with asbestos, using the appropriate ventilator masks. Again, the idea is that we should start thinking about CAT scans of the chest as a medical necessity. Just like you say, well, I got to get my mammogram this year, I got to get my CAT scan this year. It's no different than the screening for mammography, pap smears, PSAs, colonoscopies. It should be a routine screening test that everyone's knee-jerk reaction is, my ear is up, it's time for my next scan. And most importantly, you shouldn't panic. A lot of patients are going to have nodules in their lungs, and a nodule does not mean cancer. There's probably a gazillion nodules out there, of which very few percentage-wise are malignant. This is where it's important to follow up with the physician that ordered the test, go over the results, and then oftentimes there'll be additional scans coming down the pike. So the key is to not panic with the first interpretation, but follow through with your doctor. I think we're going to wait for questions till the end, right?
Yes.
Okay, great, thank you.